A very good morning to all of you. My name is Arosha Disanayaka. I'm the president of the Ceylon College of Physicians. And then the Ceylon College of Physicians, all of you know, is the professional body in which all physicians gather together. We have the general internal medicine or the internal medicine specialists, as well as all the specialists from the finer specialties such as cardiology, neurology, respiratory, etc., all joining us as one group. So we are the Ceylon College of Physicians. And then, of course, this webinar is focused. The purpose of organizing this webinar has been, as we all know, a hesitancy, a vaccine hesitancy we've noted over the past few months about taking the vaccine, especially the booster dose of vaccine. And then, of course, there are so many stories circulating that at times even medical professionals feel they need more information to reassure their patients that the vaccine is safe and effective. And the purpose of organizing this webinar has been to address that need, that is to speak to the doctors and give them an opportunity to clear all their doubts from a group of experts so that they can in turn convey that information to their patients. So that has been the objective of arranging this. And then, of course, this was organized by, within the Ceylon College of Physicians, we have something called the Infectious Diseases Forum, where experts with an interest in infectious diseases get together and then discuss different illnesses at different times. They have spoken about different illnesses, but over the past 1 or 2 years, the focus has been on COVID. So Dr. Vimarasuri Uluwatha, who is a consultant physician and a member and a fellow of the Ceylon College of Physicians, is the convener of the Infectious Diseases Forum, along with the two secretaries, Dr. Nilanka Pereira and Dr. Shehan Silva. Their forum has organized this activity, which I think is a timely need and an extremely important event. And then, of course, joining us as resource persons are three eminent people who have done a lot of work on COVID-related matters. Dr. Ananda Vijay Vikrama, past president of the Ceylon College of Physicians, and joining him will be Dr. Harsha Satish Chandra and Professor Neelika Malavige. I mean, all these three names are well known to you. They are well known to the general public as well. They are excellent through their excellent work with regard to COVID. And to moderate this session, it is my pleasure to have Dr. Upul Disanayaka, again a fellow of the Ceylon College of Physicians, and a physician who has done a lot of work at the front line with regard to COVID. So this is a great opportunity for all of us to clear our doubts. And then I would like to hand over the proceedings to Dr. Upul Disanayaka to take on the conduct of this meeting from here onwards. So I thank all of you for joining this morning, and my only request from you is, once you get to know all that you want to know and clear all your doubts, please convey this message to all other doctors whom you come in contact with, so that you all can be the catalyzing force for a change in the approach to vaccines in Sri Lanka. And then, of course, every time you see a patient, please ask them that they've had the booster doses, and then, of course, convey all this information to them. So hopefully we will have a wonderful session. Pul, over to you, please.
Thank you, sir. That is Professor Arosha Disanayaka, the president of Ceylon College of Physicians, and thank you for that introduction. Ladies and gentlemen, we hear that the COVID is spreading very fast in the country. On the other hand, it seems a very mild infection compared to Delta. So, how is the situation in the world, Sri Lanka, and NHSL in particular? Dr. Harsha Satish Chandra, as the former president of the Sri Lanka College of Internal Medicine, I think is the best person to answer this. Satish?
Yes, Upul. Now, if we take Sri Lankan data as of today, as of a couple of days back, we have about 617,000 confirmed cases and deaths 15,572. And another point that should be stressed is that people in hospital and home-based care, so that is patients who have active COVID-19, comes to a number of 20,847. So that is a quite a significant number. With the advent of the Omicron variant, I think we have seen a sharp rise in cases. And now, if I give a little bit of data about the National Hospital, now as of today, we have about 300 patients receiving treatment for COVID-19. And out of that, 75 are oxygen dependent. So, I mean, that's a quite alarming statistic, because that does mean that about 25% of patients are oxygen dependent, and this is in spite of this being the Omicron variant. So it looks as if the Omicron variant can be quite serious in certain patients. So if we analyze the patients in HDUs and ICUs, one common factor that we come across is that most of those patients are not vaccinated. Actually, there are some who haven't received any of the primary vaccination doses, and there are some who have received just the primary vaccination doses, or maybe just one, and most of them, and I think almost all of them, have not had the booster dose. So I think that's quite an alarming population. This is in consistence with data around the world, even in the US and the UK. People in HDUs, ICUs, and even in hospitals, they have a disproportionately low rate of vaccination. So it's quite clear that even with the Omicron variant, the unvaccinated people are causing a severe burden on the health systems. And the tragic factor is that in spite of vaccination being available, people have not taken the vaccine. And if I may give a little bit of data about Sri Lanka. Now, I think about in Sri Lanka, over 16 million people have received one dose of the primary vaccination. That amounts to about 75%. And about 14 million have received the second dose of the primary vaccination. So that comes to about 70%, close to 70%. And and the booster uptake is about 37% as of yesterday. So, I mean, this is in spite of there being vaccines here, there is no shortage. So I think we need to move on with this. And the other thing is, another concerning factor is that out of 2.5 million people who are estimated to be over the age of 60, only 1.3 million people have had the booster. So there is a large population out there, 1.5 million, who have not had the booster. And another important factor is that in the Western province, and especially in Colombo and Gampaha, the booster uptake is quite low as about 21%. So I think we need to examine the factors behind this. And let me once again stress on the fact that the Omicron variant, though said to be milder than the Delta variant, can still cause quite severe disease in the unvaccinated.
Thank you, Harsha. Now, the next question goes to Dr. Ananda Vijayavikrama of National Institute of Infectious Diseases. Ananda, do you see bad cases of Omicron at National Institute of Infectious Diseases, or is it very mild upper respiratory tract infection?
Yeah, I think as Dr. Satish said, we see a lot of cases. We hear about a lot of cases. It is spreading quite fast in the country, and most of them are, or quite a majority of them are, having mild symptoms. However, when you consider the hospitalized patients, we see severe cases and bad patients also. As Satish said, there's a proportion of or rather significant proportion of patients who need oxygen and who need more support, which means they are having severe illness. That is noticed in other countries too. We have to just quote an example. We know in the present context, in the US, about 2,000 patients die of COVID, and they are in the US also. It is Omicron variant which is spreading. Now, this is just to highlight one of the patient's X-rays we are having at the moment in the in our ICU. This is a 43-year-old male, unvaccinated, came with hypoxia, with a history of 5 days illness, came admitted with hypoxia, and this was his chest X-ray. You can see how much the lung has got affected, and this shows the CT scan, again showing how badly the lungs have got affected with the fibrosis setting in, and a lot of changes suggestive of pneumonia. And this just a 43-year-old male, an unvaccinated person. So this is what we see. We see severe cases, especially among unvaccinated people, and also in some cases are there in people who have not had the booster dose. Up to now, I haven't seen any patient with severe disease who had the booster dose. There are patients, or there are people who develop symptoms of COVID and proven to be COVID in spite of having the booster dose too. However, I'm yet to see a patient with severe illness who had the booster dose. So, as Satish said at the beginning, it is difficult to understand when this is available, when the vaccine is available, why people are not taking the booster dose. And in fact, the purpose of this is to address some of those issues and queries. Thank you.
Thank you, Anand. This next question goes to Professor Nilika Malavige. Now, getting Omicron seems to give you immunity. Now, instead of spending millions of dollars and enriching the multinational companies, shouldn't you let it spread?
So that's a good question. Now, at the beginning of the pandemic, everybody was talking about herd immunity. We can achieve herd immunity through vaccination or natural infection. And and the initial Wuhan variant, if it spread, I mean, some countries were considering just letting it spread, but then there were a large number of deaths. But the question here is, since we have Omicron now, can't we just let it spread because it's milder, and then we achieve herd immunity, and we can end the pandemic by achieving herd immunity? Now, to answer that question, let's think about something like measles. Now, if somebody gets measles, a natural infection, that prevents the person getting measles ever again. So it's called sterilizing immunity. Natural infection with measles prevent a person getting measles again. And after 2 doses of the measles vaccine, that also prevents the person getting measles again. And we know that there are no variants of measles. In contrast, the SARS-CoV-2 is a coronavirus. And unfortunately, although people had a rosy picture and a lot of hopes that we can end this pandemic in such a manner, the immunity to coronaviruses is not long lasting. So if you look at the other human coronaviruses, the immunity to prevent reinfection for the same type of variant does not last for more than 2-3 years. So if it was the same variant, again you will get reinfected. But the problem here with SARS-CoV-2 is the emergence of these different variants. So when different variants emerge, it is not possible to sort of end the pandemic and by just letting everybody get Omicron, because it doesn't work like that. And even if everybody does get Omicron, because the immunity to Omicron will also decline with time, people will get reinfected with Omicron. So this is the reality, and of course the global vaccine companies and the WHO is taking a different approach to address that issue.
Thank you. Now, when we were given the first dose of COVID vaccination, we were told that it will stop the infection and spread of the infection as well. You don't get it, and it will stop you transmitting it to other people. And it did. And then we were told to get the second dose, and they told us there won't be any the deaths once you get the second dose. Now we are told to get the booster dose to stop the deaths happening. So this is too much.
Yes, so that's a good question, and everything is to do with new variants emerging and of course the waning of immunity. But then the question arises, do we have to take booster dose forever? And that would not be an issue here. So if I can just show you some data. Now this is, if you look at I'll get the pointer out. Okay, so this is in Switzerland, and you can see in old age groups after 2 vaccines, of course, the death rates is very much lower than unvaccinated individuals. There's no question about it. But you can see, especially after the booster dose, the number of deaths in these individuals is so much lower. So this is in Switzerland. Now, if you look at United States, again, not only in the older groups, not only in individuals over 65 years, but also in individuals between the 18 to 49 group, there have been some deaths after 2 doses of vaccination. Of course, we know that US used Pfizer, Moderna, the Mrna vaccines, or Johnson & Johnson. So even after fully vaccination, even in the younger age group, there were some deaths. But with the booster dose, this disappears. So nobody, especially in the young age group, dies after a booster dose. And even in the old age groups, the deaths after a booster dose is very much lower. And this is the overall deaths, all ages combined. So people who have received 2 doses of the vaccine are 14 times less likely to die than unvaccinated individuals. But people who have taken the booster dose are 97 times unlikely to die than unvaccinated people. So I think that's a huge drop in the chances of dying after the booster dose. And if we look at our own data, this is from the Colombo district from 22nd of January to 31st of January. There were 28 deaths in the over 60 population, and nobody who got boosters died. So nobody who got boosters were included in that population. Now, of course, we are talking about death, and when it comes to younger people, of course, I mean, most younger people get mild infection, except a few people who might get severe disease. But what about hospitalizations? Now, this is data from US that shows so this is the emergence of the Omicron outbreak in US, and you can see the hospitalization rates in unvaccinated individuals have shot up. And this is the hospitalization rates in fully vaccinated individuals, those who have got 2 doses. Of course, it is so much less if you get 2 doses, the hospitalization rates. But these are the hospitalization rates of individuals who have got boosters. So you can see that not only boosters prevent deaths, but they prevent severe disease and the need to go into hospitalization in all individuals. So I think this is enough data to show the usefulness of booster doses.
Ananda, anything that you can contribute on this?
Yeah, I think this word booster has created some problems in the minds of some people. There's a lot of sort of inquiries. Now, if you take a booster, will I need another booster? This is not going to end. Like some people think like that, it seems. But then we have forgotten that giving boosters in vaccines is not a new thing. After getting an injury, it's common if you go to a hospital to get a tetanus toxoid, and that is a booster. Now, we are giving in our childhood 3 doses of toxoids or tetanus vaccine, and the third one is a booster, of course. And then subsequently also, if you get injury and also in pregnancy, you are given a toxoid dose, and that is a booster. So that is not a new concept. That is a common thing with many vaccines. Some vaccines it is 2 doses is enough, but in some other vaccines you need to have a booster. In health sector, it is common to give a booster dose of hepatitis B to everybody, and in some countries they give hepatitis B booster to all the population. So this is not a new thing. That is to increase the immunity which is declining over time. So you will have good immunity with after the booster, better immunity after the booster. Your immunity which was going down will be increased again, and then you know you are protected from getting the disease, and that is the purpose of giving the booster.
Thanks, Ananda. Now, there is this vaccine lobby which claim that with time the antibodies wane off. But I think any basic immunology textbook would tell you that it is the memory cells which is important in vaccine mediated immunity. Why do these people mislead public into this? What do you have to say about this, Nilika?
Yes, so that's a good question. And if I may show some slides and explain what we are talking about here. Now, in SARS-CoV-2, how it causes infection is when the virus binds to the ACE2. And what antibodies do, not any antibody, but those that bind to the receptor binding domain are called neutralizing antibodies. What they do is to prevent the binding of the viral spike protein, the receptor binding domain, to the ACE2 that prevent infection. Now, if you look at the SARS-CoV-2 virus, it has 4 main sites where these neutralizing antibodies bind to. Now, in Omicron, there are mutations in all of these 4 sites. All 4 sites are mutated. So, then there is an issue of neutralizing antibodies binding. Because of this, the neutralizing antibodies don't bind properly because there are 4 mutations in all 4 sites, and this is why we are seeing a lot of reinfection and evasion of vaccine-induced immunity. This is why also, because the antibody, all 4 antibody binding sites are mutated, and this is why these antibody cocktails are ineffective for Omicron as well. Now the question comes about memory, and I mean, if they are not binding, what happens? And I just showed you data showing that boosters work, and if the neutralizing antibodies can't bind, how come the boosters work? You are producing the same antibodies. Now the question here is, the neutralizing antibodies are important in preventing infection. But once the infection is established, what is important are T cell responses. And neutralizing antibodies actually prevent binding, and there are so many other types of antibodies that actually have a lot of other effects like complement activation, phagocytosis and so on, which I won't describe here. But antibodies have other functions apart from just neutralizing the virus, and also once the virus infects you, the T cell response is important. Now, when you look at Omicron versus other variants, so this is the initial Wuhan variant, and the other variants that came along are different but quite close to the Wuhan variant. Omicron is way away, so it's very much different than the original Wuhan variant. So because of this, the memory B cell responses that are induced following vaccination are only 50% specific for Omicron. But after a booster, because the memory B cells also evolve, and the memory B cell response becomes very much broader. So the breadth of the immune response is important, and it becomes 70% specific for Omicron. And so this is what is shown. So for instance, after 2 doses, with time the neutralizing antibodies decline, especially this is for Omicron, almost none, but with the booster dose you can see the neutralizing antibodies going up even for such a long time, because studies have been done because booster dose were given in other countries earlier than ours. So because of this evolvement of the memory B cell response, and also all of the T cell response was not very much impaired after 2 doses of the vaccine for Omicron, but with the booster dose, the T cell response also increases by 20%. So all these things are important to prevent reinfection with Omicron. And Omicron reinfection is a thing with Omicron because it escapes all the neutralizing antibody binding sites all these are mutated, so you get reinfected. So previous infection protection against reinfection with Omicron is only 19%, and this is the proportion of reinfection in New York, and you can see the proportion of reinfection in UK, and UK just released this data of deaths, and these and you can see the reinfection causing deaths in a large proportion of patients in UK because of Omicron reinfection. So these are unvaccinated people. So this is why vaccines plus a booster is important.
Thank you. Dr. Harsha Satish Chandra, there are these concerned doctors who raised the alarm about the serious side effects of booster vaccine. I recently saw a YouTube event where there is this group called COVID Mrna Vaccine එකමුතුව claim that there are more than 1,300 cases where they have witnessed in clinics conducted all over the country by them in 10 districts of Sri Lanka, there are a lot of people who have side effects, serious side effects. And they even claim that their work is being hampered by other concerned parties. Does the world have a mechanism to collect data of side effects? Do we have data for this? And what is riskier? The vaccine with so many side effects, or in the majority of people, it's a mild upper respiratory tract infection even with the Omicron. What is riskier? Is it the vaccine which is riskier or the illness? And do we have data in the world about the side effects and in Sri Lanka?
Yes. Now, actually, if we take the background of this, I think Nilika has made it very clear that the booster is needed, vaccination, primary vaccination, and the booster is quite necessary for us to face this Omicron variant. So the next question would be, is the vaccine safe, as you correctly asked me. Now, if we look at data around the world, I think now probably about billions of vaccine doses have been given out in the world. And if you analyze the data, it's quite clear that side effects have been very rare. Of course, there were some side effects. I think initially we may remember that when the AstraZeneca vaccine was rolled out, there was a concern about the formation of thrombosis with thrombocyte, the occurrence of thrombosis with thrombocytopenia, cerebral venous sinus thrombosis occurring with thrombocytopenia, and of course other episodes of thromboembolic events like DVT and pulmonary embolism. But those, of course, were in a defined population, and that was associated with the AstraZeneca vaccination. We did not see that many in Sri Lanka, but there were a few cases, I admit. But now we are talking about the booster vaccine here, where the Pfizer vaccine is given, and clots with the Pfizer vaccine are very, very rare. And actually, that's all. It's major thromboembolic events could very rarely happen, but then they are quite rare. If we take Sri Lankan data, I actually discussed this with the epidemiology unit recently, and what they said was that now we have given out the Pfizer booster vaccination to about 5.6 million people in Sri Lanka. That's about 37% of the population, and reports of clots occurring are almost non-existent. There have been some instances of anaphylaxis, which is to be expected, and they were all mild cases of anaphylaxis. Then they did investigate 3 deaths that occurred that had a temporal relationship with the vaccine. Now, that doesn't mean that the vaccine caused it. Those deaths had happened after within a period of about 2 weeks of the vaccine. And when they were investigated, 2 had actually happened due to cardiovascular disease. And when postmortems were done, it was very clear that there were plaques occurring in the coronary arteries and cerebral vessels. And so those were actually cases of deaths that occurred in previously existing advanced cardiovascular disease. And there was one death in a patient from I think in the North Central province, where she had died after a day or 2 of the vaccine, but she had severe asthma, and there was anaphylaxis implicated in that. So that was a particular case, and that's being still investigated. So other than that, there have been no major cases of adverse events with the vaccine. And it's very heartening to know that we have given this vaccine to more than 1 million children in our country in the 12 to 19 age group. And no deaths have been reported. No major adverse events have been reported. Now, I think you may be aware that with the Pfizer vaccine, there is a risk of, there is a supposed risk of myocarditis occurring. And even in worldwide data, it is said that the chance of myocarditis occurring is about 10 per million doses, which is very rare. And also most of the cases are self-limiting, and the patients improve with rest and very mild treatment. So they actually there have been no major deaths, no deaths reported. And in Sri Lanka, there have been no reports of myocarditis, even though more than 1 million doses of the vaccine has been given to children and young adolescents. And so this is something that we have to take seriously. So again, I think I must emphasize that this major issue about clots is a myth. And as Upul said, there have been groups of doctors, not doctors exactly, groups of people and some in the profession as well, who have said that there have been adverse reports of adverse events, and I think there is no truth behind this. And another thing that I would like to stress upon is that this incidence of anaphylaxis, most of the reactions are very mild. In fact, in the US now, they have done away with this 15-minute monitoring period after vaccination. Now, I mean, even in Sri Lanka, we do practice that. We hold the patient for about 15 minutes to see whether there is any adverse event. So US has said that they are so rare that there is no need to do that, and they do it only if patients have shown allergy in the past to vaccines. So it's quite clear that the side effects are quite minimal. And a major thing that people say is that I got to hear that probably a neighbor or somebody else had a stroke or myocardial infarction following vaccination. So they question whether the vaccine had caused it. Now, there have been studies around the world which have examined the incidence of MI and stroke in a given locality following the pandemic and vaccination compared with previous data. Now, of course, we do know that in the age group over 60 and in patients who have multiple comorbidities, there is always the chance of an MI or a stroke happening. So cardiovascular events are common in that age group. And when they studied, they found that if you take a given locality following the COVID pandemic and the vaccination, there have been no increase in the background in the rate of occurrence of MI or stroke anywhere in the world where these studies were done. So it's quite clear that there is no data to support the fact that there is an increase in MIs and strokes. So I think most of the time what is misinterpreted is a temporal relationship. A person gets the vaccine, 2 or 3 weeks later, there is a myocardial infarction or stroke, and then people jump to the conclusion that the vaccine had caused it. But in fact, that was in a group of individuals who were very prone to getting these events, and the event rate is not different to the rate that existed before the pandemic and the vaccination program began. So I think we should feel assured that there is no increase in risk. And so in Sri Lanka, the other important thing that we have to consider is that now we are talking about the booster in a population that has been that has had primary vaccination to a degree of 75%. I mean, that's quite a high number. So, and we have not had major reports of adverse events. So I think this fear of the booster causing adverse effects is actually quite unfounded. And in fact, we are actually now giving a vaccine that causes less side effects in all age groups. So I think it's an important fact that we should stress, an important factor which we should take into account when deciding on the safety of the vaccine.
Thank you very much, Satish. You have convinced me. What about Anand? Do you have anything to say about this?
Yes, in fact, when the vaccines were approved to use in Sri Lanka, our Sri Lankan Medicines Regulatory Authority, or the NMRA, appointed a committee consisting of specialists from various fields in medicines like clinical internal medicine, immunology, virology, respiratory medicine, and so on. I was one of them, and Nilika was another. So we had specialists from various areas. And when we considered these vaccines, the main thing we considered was the safety of the vaccine. That was the main thing. the first thing. The second thing was the efficacy of the vaccine. And not only in Sri Lanka, even in other countries, that is same. When a vaccine is approved, what is considered first is the safety and then the efficacy. For example, if you look at the FDA or CDC explanations on this, now you can look at this website from CDC, and when they initially approved the Pfizer vaccine, when they gave the emergency user authorization for the Pfizer vaccine, they used the data from large randomized trials. Now all these vaccines had large randomized trials. Now this had 36,000 participants, 18,000 for the vaccine group and another 18,000 for the placebo group. And when, as you know, when these are followed up, they are looking at the efficacy of this as well as the side effects of this. So this showed the vaccine was 95% effective, and also they were followed up for the safety duration of the duration to see whether they develop any side effects. So the initial final evaluation, there were more participants, and also when you take the phase 2 trial, that also was added to this. The 22,000 vaccinated people in the vaccine group, and then another 22,000 in the placebo group were compared. And then they were followed up for several months to see whether they develop any side effects related to vaccination. And even after the issuance of the emergency use authorization, these patients have been followed up in the trial participants. So about 12,000 participants are followed up in this study for at least 6 months. And then of course there were adverse effects, of course, but most of those, almost all these adverse effects were mild adverse effects. Now in the vaccine group they say 64 and 6 placebo recipient reported lymphadenopathy. And we know the common things we have noted in Sri Lanka too, the shoulder pain, the right axial lymphadenopathy, and then this follow-up, it had been shown that few had paroxysmal ventricular arrhythmias and some paresthesia in few patients. And in fact, in the group, there were 6 deaths, 2 in the vaccine group and 4 in the placebo group. Now that does not mean the placebo caused deaths, but all these deaths were not related to either to the vaccine or to the placebo. So this is just one study. So we have evaluated such studies on our own as well. Not only this study, even for other vaccines, we have evaluated these things. And when we were assured of the safety of the vaccine, that the vaccine, the side effects are not serious, only then we approved this vaccine. And also when the efficacy was significant enough. If there was a doubt, we would not have approved this vaccine. In fact, if you look at the past, about 4 years ago, there was an attempt to register a dengue vaccine. And that time, we did not approve that, even though the WHO has given a sort of a temporary approval, we did not approve it for Sri Lankans because we had concerned about the safety of that, which was proven to be correct later. So, if there was a problem, that would not have been approved. And since we were assured of the safety of the vaccine only, we approved this vaccine by the National Medicines Regulatory Authority.
Thank you, Anand. Now, recently I was talking to a young adult who was not very keen on taking the Pfizer vaccine. Now, I asked him why. He said there is this the very plausible explanation. He said there are a lot of reports of young people getting erectile dysfunction and that is impotence. And Pfizer is the very same company which invented Viagra. And he says to improve the sales of Viagra, now this vaccine is being given, and it is known that this vaccine is causing erectile dysfunction. What do you say, Ananda?
Yeah, that's a worry people have, not only about the erectile dysfunction, about the subfertility, about this getting strokes, infarction. In fact, to begin with, if I may quote an example, a true story, a friend of mine is admitted at the moment. He came with cough and shortness of breath going on for 10 days. I took X-ray. And that showed COVID pneumonia. Then we did the PCR, COVID was positive. So I was admitted, he was admitted and I was treating him. And 2 days later, he had a stroke. He had a stroke which was proven by the scans. He developed weakness of the left lower limb. And he had not had the vaccination. He did not have any vaccine. And now he has got pneumonia and stroke. In fact, it is COVID which tend to cause these problems. Not only the strokes, the COVID can cause erectile dysfunction. COVID can cause temporary subfertility in males, because with COVID the sperm count tend to go down when you get the COVID infection. So these problems actually occur in COVID, and none of those problems have been reported with the vaccine. So we have enough evidence to say, not only in our country, in other countries these things have been studied more, and there's no evidence to say that the vaccine causes erectile dysfunction or subfertility. So it is quite safe for young people to take it, and in fact it will prevent, as I said, if they get the infection, then there's a possibility of getting this erectile dysfunction or temporary subfertility. So take the vaccine, so you are protected and you will not get erectile dysfunction even if you get COVID.
Thank you, Anand. Now, Nilika, the Pfizer vaccine, unlike the Sinopharm and the AstraZeneca, is a RNA vaccine. And can't it modify the genome of our people? Could this be a Western conspiracy to change our genome for their future machinations? What do you think about it?
Yes. So I think first of all, we have to come into that question. Last week, the world had given 10 billion COVID-19 vaccines. So 10 billion, and of those 10 billion vaccines, over 1 billion were Pfizer vaccines and another 1 billion were Mrna vaccines. So we are talking about around 2 billion mRNA vaccines being administered throughout the world. Which is 2,000 million. So that's a very, very large number of mRNA vaccines being given. Now, although the world heard about this mRNA technology with COVID, actually these mRNA vaccines have been undergoing clinical trials for patients with cancers since 2010. That is 12 years ago. So these were actually made to, because they are more immunogenic than, let's say, a killed vaccine. And we know that in cancer patients, they have a weaker immune system. So in order to have a good immune response as a cancer vaccine, these mRNA vaccines were developed and were undergoing clinical trials since 2010. And people were quite comfortable with these. Then scientists became more and more comfortable with the platform and had a lot of data about how these mRNA platforms work and how they can be rapidly mobilized. So when COVID came, it sounded very rational if you want to have a fast vaccine which is very immunogenic to go for mRNA platform. And we know by now over 2 billion mRNA vaccines or even more have been given. And we have to understand that in mammals, including humans, we have a DNA. There is no way that RNA can get incorporated into our DNA. So there is absolutely no truth that the mRNA, which is a messenger RNA, piece of messenger RNA, which gets rapidly degraded inside cells, would cause any sort of issue to our genome.
Thank you, Nilika. Now, this question goes to Dr. Anand Vijay. Now, when this illness started, we had nothing to treat it. And there were a lot of drugs being promoted, but eventually all of them were not effective. That's why we were interested in the vaccines. But now, we have the treatment. Say there is this molnupiravir, and then the monoclonal antibody cocktails and tocilizumab. Why should we do away with vaccines but treat like any other infection? You treat the UTI with antibiotics. Like that, why can't we treat the COVID patients rather than try to stop COVID, since we have the treatment?
Yes, in fact, over the last couple of months, a lot of publicity had been given to some of these drugs, especially molnupiravir, even in Sri Lankan media. So it's now this is one such news item which said the approval had been granted for 6 importers for molnupiravir, and this was in January, and even earlier than this, that was in November. The state minister saying that molnupiravir to be imported to Sri Lanka next week. It didn't come out though. So the news item. This right side picture I didn't put purposely. That was in the web when I took this the snapshot. If you look at molnupiravir, it is been approved in some countries as an antiviral for COVID-19 vaccine. COVID-19. And this is from NIH. Patients should complete a 5-day treatment course of molnupiravir. It is unknown whether a shorter course is less effective or associated with the emergence of molnupiravir resistant mutations. Now that latter sentence brings us to this important issue of mutagenic risk in molnupiravir. It has a mutagenic ribonucleoside antiviral agent. So there's a theoretical risk that it will metabolize by the human host cell and incorporate it into host DNA, unlike the mRNA vaccine, which can, this of course a theoretical risk. However, there had been studies done in rodents, and one study produced results that were equivocal, not negative, equivocal. And the other study though said there was no evidence of mutagenicity. However, the FDA in the US concluded that based on the available genotoxicity data and the duration of treatment, it has a low risk for genotoxicity. Now, in addition, there's concerns. Now, all this is from the NIH treatment guideline. You can check this in the NIH treatment guideline. In addition, there have been concerns about the potential effects of molnupiravir on COVID mutation rates. So the FDA is requiring the manufacturer to establish a process to monitor genomic databases for emergence of COVID variants when molnupiravir is being used. So this is being used in the UK and in some other countries, and WHO might give a conditional approval to this because they were considering the people where in countries where people have no access or limited access to vaccination. Why is that? Is it efficacious? Of course, this is another part from the same guideline, NIH guideline. Because of this potential risk of mutagenic nature of this drug, it is advised when it is given to childbearing females to use contraception for 4 days after receiving molnupiravir, and for males to abstain or use contraception for 3 months after last dose of molnupiravir. So in case if you are giving it to anybody, please you need to educate them on this. Otherwise, if there's a problem, of course you may be sued. But then how is the efficacy of this? Now the main study which is done is called Move Out study, which shows that was analyzed in the midway. The total number was to be about 1,500, 1,400, but in the midway it was analyzed when about 700 or 750 patients, participants are recruited, and that shows hospitalization death occurred in 28 of 385 participants, that is 7.3, and in the other placebo group it had been 14%. So there was a significant reduction or 50% reduction with the drug. But when they analyzed the other part, this significance came down, even though still it was significant. It came down to 6.8 and 9.7, so the efficacy came down. This is what is shown in the publication related to the study. What is not shown in this publication is this analysis of the second half of the vaccine, second half of this drug. So it was analyzed midway, and when it was fully analyzed, the efficacy came down. But if you analyze the second half of this study after the interim analysis, this shows 20 deaths or hospitalization in 324 participants in the drug group and 15 in the placebo group. So it is actually less in the placebo group. So that is an issue. We thought that is an issue because if the second half came first, this drug would have been never approved. So for that reason, and also for the risk of having these mutagenic effects and so on, the expert group decided not to approve this for Sri Lanka, so it is not approved. And on the other hand, even if it was approved, now it has been found that it is not effective with the Omicron variants. So even though it was approved, it is going out of use even in other countries where it had been used for a short period. If you look at other treatment, this was approved, the antibody cocktail was approved for limited use in Sri Lanka with the specific conditions to use in hospitalized patients who are not on oxygen, who are seronegative for COVID, because the study showed it is effective only in seronegative group, not in the seropositive group. So we have specifically included that. And the patient who has high risk of getting infection, severe illness like immunosuppressed or patients on immunosuppressants and other conditions which can cause genetic and other problems. So seronegativity should be the NMRA requirement to use for this drug is the seronegativity should be confirmed before starting the drug, and be recommended. 2 consultants should be recommended because of course when this was the publicity given, there was pressure from the family and so on. However, even this is now going out of the list of treatment because with the Omicron variant, this is also said to be not effective. So even now this is going out of this. But we have of course the tocilizumab that is still effective even with Omicron, but the issue here is that it is effective only in severe cases. It is used only in severe cases. So if they are hypoxic, if their hypoxia is getting worse, and in spite of giving steroids, and then you have to consider whether to give tocilizumab, and that should be given after excluding concurrent sepsis. So therefore it is important to exclude the concurrent sepsis, because otherwise with immunosuppression with tocilizumab they can develop severe sepsis. And this slide shows this picture I took from 2 vials given in a private hospital. This patient needed we had to have 2 vials because the dose exceeded one vial. Now if you look at closer, you can see even though they were given by the same supplier, you can see the 2 vials are different. And when I look into the leaflet of this, I found that it is produced in Turkey. And when I look at the other things and ask from others, there's no plant of Roche in Turkey. So obviously it's a counterfeit drug. This is what had been available for the last couple of months. So if you're using tocilizumab, make sure that you use the correct drug, not a counterfeit drug. And of course we use dexamethasone again in severe cases. So there are drugs for the severe cases, but of course it is important to prevent severe disease because the effect of these drugs is also limited. It is not effective 100%. So therefore it is important to prevent severe cases. That is why the vaccination is important.
Yes, Harsha, anything about this?
Yeah, I think Upul asked this question, since there are effective treatments like steroids and tocilizumab, why we should be concerned about vaccination. Another point to add to all that Anand said is that in the recovery trial, when they examined the effect of IV dexamethasone, still about 20% of patients had mortality. So, I mean, even with that effective treatment, there was a significant degree of mortality. And when tocilizumab was tried again in the recovery group, again by the recovery group, still there was about 24% of mortality in patients who were given steroids plus tocilizumab. So I think it's very clear that even with those treatments, although they have revolutionized the treatment of severe and critical disease of COVID-19, the mortality is not zero. The mortality is quite significant, and that is why we should prevent the patients getting the illness in the first place through vaccination. Yes, and the one other important thing I think I must stress on here is that now there is a tendency to use steroids, especially dexamethasone, in early part of the disease, and this is very counterproductive, because if we give steroids to patients in their first few days of symptoms, the viral clearance will be definitely much lower, and the patient can go on to develop complications. So it's very important that steroids are given only in selected patients when they become hypoxic, when the oxygen saturation at rest drops below 94%.
Since we are nearing the allotted time, I have to take questions from the audience. Now there are very vocal. We have a lot of questions coming. One is that the Sinopharm vaccine is being given in all over the world, and why not a booster with Sinopharm? Why we have to bow down to the Western pressure and give Pfizer as a booster? Isn't Sinopharm a good alternative as a booster vaccine? Nilika.
Yes, so that is a very good question. Sinopharm is one of the vaccines that were used in most Asian and Middle East countries. And when you do head-to-head comparison with the Sinopharm versus the mRNA platform, although Sinopharm is immunogenic short-term, long-term, the immunity wanes. And this is not surprising given that it is an inactivated vaccine, because we know that other inactivated vaccines, like for instance the polio inactivated vaccines, I mean we have several other inactivated vaccines which are used in childhood vaccination programs, and you get short-term good immunity, but the immunity wanes very fast. And the other thing is, we know that as far as COVID is concerned, the most susceptible individuals are older people and those with comorbidities. And after assessing the data, Sinopharm immunogenicity data, the WHO recommended a third dose. So that is not a booster dose. Individuals who are given Sinopharm should be given a third dose if they're over 60, and then additionally a booster dose, a mRNA vaccine. So mRNA vaccines, as I mentioned earlier, were actually trialed in cancer patients who are immunosuppressed and are immunogenic. So because we can't be giving boosters every 6 months or so, it is decided, like that is what is practiced in every country. It is nothing to do with who produces the vaccine, but rather what is the vaccine construct. So because mRNA vaccines are currently the most immunogenic vaccine platform, as boosters, mRNA vaccines are used all around the world.
There's a question coming from the audience again. This goes to Dr. Anand Vijayakrama. Pfizer vaccine has caused myocarditis. There are these sudden deaths among otherwise healthy people according to social media. How can you justify using this vaccine in our children and our young adults?
Yes, now as I said initially, when the vaccine was evaluated in about around 40,000 cases, the myocarditis was not reported. Now when it is used in hundreds of thousands or millions, then these rare side effects can be noticed. Now that is what happened initially when we started using the AstraZeneca vaccine. The thromboembolism had been noted, and we also saw some cases in Sri Lanka too. But having said that, as previously mentioned also, we have not come across any cases of myocarditis in Sri Lanka. But it had been reported. In other countries it had been reported. And if you look at the CDC guidelines, they say the FDA conducted rigorous evaluation of post-authorization, and then this was noted in some patients. And this study done in Denmark, where they have a very good record keeping system, exceptionally good record keeping system, where they evaluated 4.9 million individuals over a period of 1 year, of which 3.4 million plus individuals were vaccinated with Pfizer. And of these, 48 people developed myocarditis or myopericarditis. Now that is from 3.4 million, 48 people developed this. And they had Mrna vaccination also, which was given to almost 500,000 individuals. And in that group, they found there were 21 cases of myocarditis in that group. Now, this is the incidence of myocarditis or myopericarditis with vaccination, which was found in a very good cohort study. Now, this has been, there had been similar other studies also, but this is a very large study with very good data. So, it can occur, but it's a rare condition, and also all these people have responded to treatment very well. So, when you consider the balance, risk and the benefit of the vaccines, it is clear we cannot go by this. Cannot go by these rare side effects, which are not even though it's a significant side effects, these are not lethal side effects. So, therefore, when it is considered the benefit, risk, and the benefit, it had been beyond doubt. It is beyond doubt that the vaccine is beneficial in spite of this rare side effect.
Thank you. Another question. Sorry.
Well, to add to that, if somebody is worried about this, if somebody wants to have more details, you can give this website of British Heart Foundation gives very good details on this. The website is shown here, COVID-19 vaccines and myocarditis, should you be worried. And also it addresses other things, like for example, like I have heard about people getting myocarditis after the vaccine and I am worried, should I have my second dose? I was diagnosed with myocarditis, what to do? And also if it addresses the issue, is there any link between the COVID-19 vaccine and collapse at football matches? Because that also another thing which had been given a lot of publicity, saying that 180 FIFA registered players have died after the vaccination has started. Some of the named people, in fact, the first player attributed to this is a Denmark player. We quoted the Denmark study, and he was playing for Milan. And but the Milan says that this happened, and this player has not had any vaccination. So some of the deaths which have happened anyway, due to maybe other reasons, have been attributed to the vaccine, unfortunately.
Another question. The school children are being vaccinated. We are told that COVID is a very mild infection in children. How can you justify giving a vaccine to children under these circumstances? Are there any scientific data backing it? Nilika.
Okay, so now COVID is mild in children. We all know that. A lot of data shows that. But the issue is, apart from the acute illness, there are things like multisystem inflammatory syndrome and also long COVID. And if multisystem inflammatory syndrome is rare again, but a study has shown, there is one very good thoroughly conducted study which shown that the vaccines reduce the risk of multisystem inflammatory syndrome by 96%. And we know that this MIS-C occurs in healthy children and you can't predict who gets it. So whereas vaccines completely, 96% prevent that sort of complication. Other one is long COVID. Now long COVID is a thing. It is not as common in children as in older adults. But again, the vaccine very effectively and significantly prevents long COVID in children. And given that the vaccine actually doesn't cause much side effects, as Dr. Sasis mentioned, over 1 million children in Sri Lanka alone have received this Pfizer vaccine and no significant side effects were observed. The way giving the vaccine far outweighs any risks that may happen. And in Sri Lanka, although myocarditis has been reported, we have not so far reported a single case of myocarditis.
Thank you, Nilika. The last question is, what are the realistic chances of superbugs, the virulence of Delta with the infectivity of Omicron overs?
So now Omicron is unlikely to be the last variant. The next variant that will have to overtake Omicron. Now, even in Omicron, we had BA1, which is the initial Omicron virus that was circulating, and then we have this BA2, which is significantly more transmissible than the initial, or let's call it Omicron version 1. So likewise, we will have more SARS-CoV-2 variants coming up. And if something is going to replace Omicron, it has to be more transmissible than Omicron, which would, of course, cause very significant outbreaks. And there is no such thing saying that the viruses that evolve, have to be less milder than Omicron. True that Omicron turned out to be milder, which is the good fortune of all of us. It is just the humankind was lucky, but there is no guarantee that the next variant is going to be less severe. And we know that recently in Netherlands, they reported HIV, new virus variant that is much more virulent than the HIV that was around, HIV 1 and 2 that has been around all this time. So to overcome these things, I mean, where do we head from here? Several vaccine companies and universities, academic institutions are jointly trying to come up with a pan Sarbecovirus vaccine. So that is sort of a pan coronavirus vaccine, which would cover all human coronaviruses and all possible emerging variants. But of course, such a complicated vaccine cannot be manufactured, developed overnight. That is going to take some time. So hopefully we will, when that vaccine comes, then we can call it the end of COVID and maybe other emerging COVID virus, SARS-CoV-2 viruses. Right now, we will have to sort of take our boosters and get on with the usual methods that we have been adopting so far.
Thank you very much. We have come to the end of this discussion about the vaccine and the COVID and its complications and the new treatment modalities. Thank you very much for coming and sort of helping us in this. Professor Neil Kamalavige, Dr. Anand Vikraman, Dr. Harsha Satish Chandra, and Professor Arosh Disanayak and Dr. Bimala Siruluatage, and the two secretaries of the Infectious Diseases Forum, and for all those who listened. And we hope that you'll help in eradicating or sort of making COVID less formidable illness in the country by advocating vaccination among the people who are reluctant. I think we have allayed your fears and any suspicions during the discussion today. And thank you very much, and have a good day. Thank you.